Welcome to the Mayo Clinic Cardiovascular Podcast Series, Interviews with the Experts. I'm your host, Sharonne Hayes. I'm a non-invasive cardiologist and Vice Chair of Faculty Development and Academic Advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. And today, I'm joined by Dr. Chadi Ayoub, who is Associate Professor of Medicine, Medical Director of the ECHO Program, and a member of the ACC Cardio-oncology Leadership Council. He also practices at Mayo Clinic in Phoenix. So today, our topic is cardio-oncology, the big picture, what drugs to use, tests to follow. With advances in cancer care, we're seeing more frequent cardiotoxic effects associated with many of these life-saving cancer therapies. And dealing with immune checkpoint inhibitors in particular has become a specialty in and of itself. Today, we'll discuss modalities that can be used to detect and evaluate cardiotoxicity, as well as common adverse cardiac events associated with immune checkpoint inhibitors. And we'll review treatment options to prevent and address this cardiovascular toxicity. So welcome, Chadi, and glad you're here to share all of this with us.
Sharon, thank you for the kind introduction, and I'm really glad to speak to you today about this really important and growing field, which covers really an overlap of two important populations, cancer patients and cardiac care.
So can you first just share the primary chemotherapy agents that we as cardiologists really should be aware of that may cause cardiotoxicity? Because it's a growing list, right?
Absolutely. It's so rapidly expanding and can be hard to keep up with. And I should comment, the word cardiotoxicity is loosely applied. Most commonly, it refers to LV systolic dysfunction or heart failure and agents that may cause this or worsen this. But it's really a very broad term that can cover many other potential side effects of cancer therapies, which could include accelerated coronary atherosclerosis, increase in cardiovascular risk factors, hypertension, QT prolongation, arrhythmias, and of course with radiation therapy, it can cause all of the above and others. So cardiotoxicity is a loose term. The literature and the guidelines, of which we have many guidelines now, and there was a complete lack 10 years ago, but this field has moved so much. We have multiple guidelines. There can be slight variations in how they define cardiotoxicity. But if we're going to use the most common and most concerning effect of cancer therapy on the heart, which is LV systolic dysfunction, that'll be the main kind of definition for cardiotoxicity. There are a couple of acronyms I should comment about. The American societies would use CT, cancer therapy cardiac dysfunction, CTCD, whereas Europeans will use a different term called cancer therapy-related cardiovascular toxicity. The bottom line is we are talking about cardiotoxicity, as you simply mentioned at the beginning, but just be aware there can be different definitions and terminologies referring to the same thing. And in concerning the main agents that can cause, say, LV systolic dysfunction most commonly, the initial group of medications was the anthracyclines, of which we have learned a lot about, and they are most commonly associated with the LV systolic dysfunction. And then the next most common group would be the HER2-targeted therapies, initially in the breast cancer space with trastuzumab or Herceptin, and then pertuzumab, and now others. But there's a wide array of other classes of cancer therapy-related medications that can cause heart failure or LV systolic dysfunction. To touch briefly on these, tyrosine kinase inhibitors, not all, but some, from the BCR-ABL class, nilotinib or palatinib might be the two most prominent. Then there's the group of proteasome inhibitors, of which carfilzomib might be an example. And then not all VEGF inhibitors, but some. And I'm thinking sunitinib, maybe top of my list, would be associated with LV systolic dysfunction in some patients who may be susceptible. So it's a long list. The European Society of Cardiology released a guideline just 2 years ago, and it's beautifully presented. And they do present tables of the different classes. So for people feeling a little bit overwhelmed with which cancer therapy drug might affect my patient, that could be a useful resource to review, as in which might be the more likely offenders.
Uh-huh. Because many of these patients obviously have been treated with multiple agents over sometimes many years, and figuring out which one that gets us to figuring out. So, if we're talking about LV dysfunction, obviously I'm thinking echo is the start, but it isn't the end for these patients. So, tell us how we would go about diagnosing. What is the surveillance or diagnostic protocol?
That's such an important question. And I like how you term it figuring out. And really, in the cardio-oncology space, it's really about risk assessment and trying to figure out who's at more risk. What's recommended across the board for all cancer therapies before they come to cardiology and even having that echo is history and examination. And this is perhaps a little bit more controversial, perhaps an ECG, just a plain old electrocardiogram, to screen patients who might be at increased risk for developing potential cardiotoxicities. Now, patients who might be identified as having previous cardiac disease on that history and examination would warrant further examination with an echo. So it's not a one size fits all. Definitely for higher risk chemotherapies like trastuzumab, and this is FDA mandated, they have to have a baseline echo and then an echo every 3 months during the course of therapy. And for anthracyclines, it's certainly recommended everyone have a baseline echo. And depending on the dose of anthracyclines, because the dose of anthracycline is really associated with risk for developing LV systolic dysfunction, then the frequency of echo surveillance during anthracycline therapy can be tailored to that patient's risk. And then for some of those other potentially higher risk medications in cancer therapy that we discussed, whether they're chemotherapy or targeted immunotherapy, it really comes down to the patient's risk. If they're low risk, then they do not need an echo. But if they're high risk, as in the patient has cardiovascular risk factors or cardiac symptoms, or the medication they're receiving, the cancer therapy risk is high. Or if they're receiving synergistic cancer therapies like radiation therapy and high-risk cancer therapies, then definitely an echocardiogram at baseline is recommended. And this is consistent in all the different guidelines in this space. It's more personalizing the frequency of surveillance with echo, which is the frontline cardiac imaging modality to detect cardiotoxicity. It's personalizing the frequency of that depending on the patient's risk and their cancer therapy and the risk of developing cardiotoxicity there. And I'd be happy to share some examples. We've talked about Herceptin and potentially anthracyclines, but for other spaces like immune checkpoint inhibitors that you've mentioned, it's debatable whether routine screening there is cost effective and of benefit to the patient. We have to think not just cost, but burden of testing to the patient. For a complication that more recent data is suggesting its frequency is 1%, perhaps not as frequent, and therefore not subjecting patients to a burden of additional testing in addition to their extensive cancer therapies and testing required there. So it really comes back to that figuring out on a patient level, what's their risk, what's their treatment, and how do I tailor that surveillance?
Yeah. So say you suspect cardiotoxicity, there's signs and symptoms, maybe the echo is abnormal. What's the next step in terms of treating it? Because obviously it sometimes, and I've experienced this with my own patients, this was the one drug that was holding their cancer at bay. And now they've had a cardiac complication, and that's such a tough situation to be in.
Absolutely. And I think that comment reflects kind of the title of this podcast, The Big Picture. And I think that's where we've learned more about kind of our role as cardiologists in the space of cancer therapy. And we've moved away from the question of, okay, there's an abnormality on testing, should I stop chemotherapy, to the question now of, how do I support the patient through the chemotherapy with this abnormality to give them this life-saving treatment that may be first line for them, and the second line may not be as effective and might actually worsen their survival and prognosis. So it's that comment is so important and shows how we've moved in this space and in this field. It really comes down to the specific situation, the degree of impairment, the drug that's being used, and what cannot be understated is this multidisciplinary approach where often it takes picking up the phone and talking to the oncologist. They are expert in cancer therapy and know what's first line, second line. In some cases, there are actually viable second and third line alternatives that have, close efficacy to their current treatment, which has potentially caused cardiotoxicity. And then that makes it an easy answer. In other cases, like the case you just described, this is really the best option for the patient. And let's take, say, the two most common offending drugs in the cardio-oncology space. With anthracyclines, the cardiotoxicity can be potentially irreversible, and it depends on the ejection fraction drop. If the ejection fraction drop is, say, mild, we would not want to withhold cancer therapy, and that'll be the first comment to the oncologist, but we would want to start what's called cardioprotective therapies. Now, we have a lot of data in the established cardiology world for heart failure with reduced ejection fraction, termed GDMT or guideline-directed medical therapy. And we have the pillars, the ACE inhibitors, sacubitril, valsartan, and Entresto in that category as well. The beta blockers, SGLT2 inhibitors, and the MRAs like spironolactone. These are the main medications used for cardioprotection when we see a mild impairment in LV systolic dysfunction when a patient is receiving cancer therapy. However, it's still controversial and the evidence is still early and limited for their application for cardioprotection as opposed to treatment of more pronounced systolic dysfunction like an ejection fraction drop below 40%. So if it's someone on an anthracycline and their ejection fraction is dropped to 50% or 45%, there's this concept now of permissive cardiotoxicity, where we would say continue this life-saving cancer therapy, but we'll screen the patient more closely with more frequent echoes, looking at both ejection fraction and this other marker on the echo called global longitudinal strain. And we would see if there's decline further despite initiating cardioprotective therapy, which in the cardio-oncology world definitely involves an ACE inhibitor and a beta blocker, with more trials forthcoming about whether SGLT2 inhibitors and statins and MRAs potentially may be helpful in cardioprotection for mild impairment. But we would initiate these on a case-by-case basis and then watch the patient closely. For trastuzumab, which is perhaps the other common medication that can cause a drop in ejection fraction, this tends to be irreversible. And again, it depends on the drop in EF. If it's in the 40s, so mild LV systolic dysfunction, 40 to 50%, we would have a discussion with the oncologist, start these cardioprotective medications and watch the patient closely. But if the EF continues to drop below 40%, then we may have to discuss an interruption and talk about other possibilities. And this approach can be extrapolated to other cancer therapies.
We hold our GDMT, what we've always done is appropriate. I guess one question is, in some patients, and there have been studies where when you start that anthracycline, you actually start the ACE or ARB. Is that standard or is that more individualized or not done anymore?
That's an excellent question. And we often get these questions from some oncologists who are asking, what's the best thing to do in my patient to be cardioprotective and to nip this in the bud before it happens? And the short answer is we do not routinely start these medications that are thought to be cardioprotective initially. It really comes back down to figuring it out for that patient. What's their risk, even with the anthracycline, of developing cardiotoxicity? If they have no cardiovascular risk factors, the EF is plumb normal. It may actually be a disservice to indiscriminately start these medications on patients receiving chemotherapy, because you have to remember, we all have to remember, they're nauseated, they're anorexic, they're dehydrated, their blood pressure is dropping, and then we're starting these medications which we thought might be helpful, but actually they make the blood pressure worse, they feel lousy, and they may not have been at risk of developing cardiotoxicity to begin with. So it's a little bit more individualized. And we use obviously echo, and then strain, this global longitudinal strain to screen for people where we can potentially pick up cardiotoxicity before the ejection fraction drops. And if there's abnormalities on this strain measurement on echo, then it may be reasonable to start maybe one or the other. That approach, I think, started 20 years ago when Dr. Cardinal initially published in the doxorubicin cohort in breast cancer ACE inhibitors attenuated decline in EF drop in that 10% of patients at that time that were going to develop it compared to people who weren't. But subsequent trials have shown actually the frequency of anthracycline-mediated LV dysfunction has become less. And part of that is we're now wiser. We know high-dose anthracyclines cause LV systolic dysfunction, so most oncologists don't give the higher dose unless they absolutely have to. And there's other mitigating techniques, say a bolus instead of an infusion, liposomal doxorubicin instead of the other formulation, and these decrease the risk. So we've seen that starting ACE inhibitors in prospective trials have shown mixed or even negative results. And that's a testament to how the field, I think, has moved and our populations have changed in terms of how we treat them.
All right, let's switch gears just a little bit. So immune checkpoint inhibitors, ICIs, it's revolutionized the care of some cancers. Tell us about cardiac toxicities here. What have we learned from our own study of these patients?
Absolutely. And I always think of former President Jimmy Carter when we talk about revolutionize the care of some cancers. When I was in medical school, I was told metastatic melanoma is a death sentence. And President Carter in his 90s developed metastatic melanoma to the brain. And then he received an immune checkpoint inhibitor and was completely cured. So it's not an understatement to say revolutionized. They do cause multiple immunological adverse toxicities like myositis, like pneumonitis, like myasthenia gravis. And then the most feared has been myocarditis, and in more severe cases like fulminant myocarditis, which is inflammation of the heart, a high mortality rate has been described. We've learned more about immune checkpoint inhibitors as time has gone on. And we know that myocarditis now occurs in roughly 1% of patients receiving immune checkpoint inhibitors. And actually, we've looked at our Mayo Clinic experience. We've looked at 5,000 patients who've received immune checkpoint inhibitors up to 2022 at all three sites of Mayo Clinic. And our data suggests that the frequency of immune checkpoint inhibitor-related myocarditis is about 1%. And it occurs in the first 4 months after receiving immune checkpoint inhibitor therapy. And we've learned that most of the adverse events, it's not kind of, again, a one-size-fits-all. It depends on how severe this myocarditis is. It could be milder on the spectrum, where potentially stopping the immune checkpoint inhibitor, treating the inflammation with prednisone, and potentially re-challenging is an option, to fulminant myocarditis, where there's hemodynamic instability, VTAC, or complete heart block, and the patient's at severe risk. So it's a spectrum, and we've learned more. Echo is important, but patients with a normal EF, even with myocarditis or low EF, it doesn't really predict their mortality. We've learned that. A low EF with myocarditis predicts more heart failure, but not mortality. But what we've learned is we need to take a more comprehensive approach, because the presentation of myocarditis can be non-specific or dramatic, and we need to use all the tools in the toolbox. So echo, MRI is invaluable. But again, for the sicker patients, they might not be able to tolerate a 45-minute examination. And in a quarter of our patients, they were not actually well enough to go down and have an MRI. So it's not a one-size-fits-all, but awareness of this complication is so important.
And the treatment, if you've got somebody who's really sick, is high-dose steroids and stopping the treatment at least temporarily, correct? Or what else do we do?
It is high-dose steroids, so IV methylprednisone for the first 3 to 5 days, and then a high-dose steroid with a slow taper. it really helps if we have confirmed the diagnosis, whether it's by MRI to get more confirmatory data, but it might be negative and that doesn't rule it out, or a biopsy if needed. But what we've learned is re-challenge with immune checkpoint inhibitors. So say we've treated them with the steroids, we withheld the immune checkpoint inhibitor. Of the 60 patients in our 5,000 roughly who had myocarditis, 6 were re-challenged. And after their troponins had settled and the acute inflammatory process had been dealt with. And actually, 4 of them did fine, and 2 had to have the immune checkpoint inhibitor stopped for other reasons, like nephritis or a rash. So it is feasible to restart immune checkpoint inhibitor if the patient has survived and support them through that initial myocarditis stage. We've looked at our experience at Mayo of additional therapies like immunoglobulin or thyroglobulin or abatacept, which is currently in trial, and I know Dr. Herman's been part of that trial. But only about 10 of our 60 patients needed additional therapy on top of prednisone, and the marker there was much higher troponin. Instead of a mean troponin of 400, we're talking about a mean troponin of 900. So we're talking about sicker patients where they might be having arrhythmias, and the cardiologist and the multidisciplinary team is concerned. We might be at higher risk of a catastrophic event, and then need to add something on top of that steroid.
Well, it's good to know that we have some of these other agents, and we look forward to your publication on this series coming out as well. Let's switch gears just a little bit to some of our older treatments. Let's talk about radiation therapy in the heart. I remember when they really didn't target, I would see patients in their 50s who'd had inflammatory breast cancer, and they'd just been blasted, and they had valve disease and coronary disease and myocardial disease and pericardial disease. And I know we do better, but it's still an issue. So what can we do to minimize radiation toxicity from a cardiology standpoint?
Again, that's such an important consideration. We've come such a long way in our understanding of radiation-related heart disease. When radiation is given, and we're talking about specifically breast cancers, lung cancers, or esophageal cancers, or thymic cancers, but it's really breast and lung where the heart's in the trajectory of those radiation, and Hodgkin's, I should say, Hodgkin's in the younger group in particular. That's probably top of the list. These patients have an inflammatory process, as you've outlined, that encompasses the whole heart acutely. It's a pancarditis. We don't have a way initially of diagnosing that inflammation, but they come to us 10, 20 years down the line where that initial inflammation triggered by that life-saving radiation therapy for the cancer has affected all aspects of the heart. It can cause valve disease, specifically the left-sided valve, and the telltale sign is that calcified aortic and mitral valve and intervalvular fibrosis on the echo. But it can cause accelerated coronary atherosclerosis, fibrosis within the myocardium, and heart failure and constriction. The whole pericardium can be encased in calcium 10 to 20 years down the line. And it really comes down to risk factor in terms of modifiable aspects from a cardiac perspective, risk factor modification, making sure all our patients who are going to go and have radiation therapy have their hypertension, hyperlipidemia fully addressed. All our patients who are going to get this therapy will have CT scans performed to stage their cancer. And it's such a useful tool for risk stratification from a cardiac perspective to pull up that non-gated CT scan, change the setting to bone, which shows calcium as white more clearly, and then scrolling down the heart and looking for calcium down the coronary tree. There's a lot of calcium and they're asymptomatic. It's like having a dedicated calcium score, then a statin may be helpful. Limited evidence for this, but it fits with our general approach in cardiology for risk factor modification. So that's what we could do. Risk factor modification, encourage that active lifestyle, because there's more patients that are going to progress to that survivorship phase, and then want to attenuate cardiovascular disease later. But then on the oncology side, there have been a whole bunch of new initiatives. Like you said, we don't indiscriminately radiate the chest as we did in the days gone past with Hodgkin's. So we've got new techniques that our radiation therapy colleagues implement, more targeted radiation to the cancer that avoids the heart, shielding the heart where possible. Techniques like deep inspiratory breath hold, where the chest is expanded and then, say, the targeted area is separated by distance from the heart, a little bit more simple technique, but so effective. And now we have proton beam therapy. So Mayo Clinic, Arizona was the first site to have proton beam therapy. Instead of using X-rays, it uses positive ions, protons, and it's thought that these protons can target the cancer tissue with a little bit more precision and so cause less damage to surrounding tissues. And I know Rochester will be opening their proton beam therapy in a year now. So there are developments in the radiation oncology space. However, I should note long-term data still needs to be established. We think this is a great initiative, but radiation heart disease turns up 10 to 20 years after the therapy. So we will probably have to wait that long to see our current initiatives, both at risk factor modification and reducing the radiation burden, to see how they bear out in the long term.
Any one-liner about where you see the future of this field or of either treatment or management or prevention of cardiotoxicity as we save more patients with these important chemotherapeutic agents?
Absolutely. Personalized risk factor assessment is critical. And that's the current state in cardio-oncology, assessing the patient's risk and the risk of the cancer, and then using the tools we have at hand. That's my one-liner for now. For the future, I think, my goodness, it's such a rapidly expanding space. Artificial intelligence, I think, is going to play a huge role in that risk factor and personalized medicine approach that might perhaps help us better screen patients at high risk, and better understanding of genetics, I think, is going to be a big player in the future as well. So I think we're going to have even more tools than we have now at identifying these higher risk patients and intervening earlier.
Yeah, I think this whole thing, we've talked a lot about the patient, but patients who develop cancer often feel like they have lost all of their agency. And being able to provide these therapies has been great, but including them, obviously, in these tough decisions, because it's the values thing and it's quality of life that often we don't forget about, but we sometimes don't pull them in. And I think that's really been a big practice as we've had to talk to each other about this and talk to the patient. So thank you so much, Chadi. This wraps up this week's episode of Interviews with the Experts. I'd like to thank Dr. Ayoub for joining me today and discussing this important topic.
My pleasure. Thank you so much.
We look forward to you all joining us next week for another interview with the experts. Be well.